Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. It's Friday Fun Day, and let me ask you a question. What is in common between ancient Egyptian mummies and modern humans? Stick till the end so that you can find out the answer. But I recently came back from a conference. It was the annual International Conference for Institute of Functional Medicine. I interacted with a lot of practitioners, and actually, as one of the faculty members, I ran with a colleague a discussion on the deeper understanding of cardiovascular risk. And it inspired me to create a little game, and I call this game Cholesterol Marbles, because I find that our patients very often are sort of picking and choosing when it comes to cholesterol profile, what they consider good and what they consider bad, and they're not necessarily putting things together. Now, you probably have heard of a microbiome, which is a collection of various microbes that live in our gut, and they shape our response to diseases or our predisposition to diseases. They are, of course, immensely impactful for processing of our food, deriving various nutrients, maintaining our gut health and brain health and heart health and even skin health and even our mood. So the cholesterol in the body actually doesn't exist in a separate silo, but it's also part of a universe, if you will, of lipid metabolism. And many lipidologists actually call it a lipidome, right? So like there is a microbiome, which is a collection of various microbes. We also have a lipidome, which is a collection of different cholesterols, triglycerides, cholesterol esters, apolipoproteins. And by studying a person's lipidome, we can actually provide them with actionable steps to shift their lipidome balance for the better. And what does this better actually implies? Well, we do want to make sure that individuals are able to engage in nutritional, supplement, lifestyle, and sometimes medical strategies that are actually positioning their lipidome in a way that reduces their vascular risk. So what are cholesterol marbles, and what am I going to try to teach you with those? Now, if you're listening to us on the audio platform, thank you so much for listening, but I would strongly encourage you at this point just to drop into our YouTube channel so that you can see the visual part of this presentation, because it will be important for you and it will help bring home quite a few points. So I use the marbles. Yes, I'm an adult cardiologist playing with marbles to illustrate certain specific components. So you could see these very big marbles. You know, I sort of have a little container and they're holding it through. These marbles represent chylomicrons. Now, what are chylomicrons? As we eat, we consume, of course, ingest various nutrients, and they get broken down into its component parts. Some of those are triglycerides or free fatty acids or cholesterol esters. And so after they traverse the stomach and the duodenum and the gut, they end up packaged into these very large particles. And these particles, you could see, they're like the biggest marbles that I have. They're called chylomicrons. Now, chylomicrons are ApoB containing particles. The specific ApoB, which is a lipoprotein, and there is one of each for each chylomicron particle, is ApoB48, right? And so ApoB48 is a component of ApoB measurement that we detect in our blood work, except that because chylomicrons are so large, they exit the circulation very quickly. And so typically when we measure ApoB, most of it is ApoB100 containing particles, not ApoB48 particles, but although a smaller component of ApoB48 particles are present. So where do these chylomicrons actually exit to? Where do they go, right? It's sort of like a show, right? Exit stage to the left. So what is the exit stage to the left strategy for chylomicrons? So chylomicrons are delivered, via blood flow, of course, to our muscle and our adipose tissue. And they serve as a source of triglycerides because they're very triglyceride rich, right? So they have a lot of fat on the inside and significantly less cholesterol, almost no cholesterol. And so this fat, then those free fatty acids, triglycerides, they get broken down and they serve as energy sources. They serve as energy sources for muscles, for example. And in the adipose tissue, they could potentially enter the storage form, right? And be stored as triglycerides. And of course, some part of these chylomicrons then gets delivered into the liver, right? So, so liver scoops them up after, and, some goes to the periphery and the rest goes into the liver. Some goes into the liver from the intestine. Some enters through what's called portal circulation, which is circulation that has to do with liver and the bile acids. But let's just say that these chylomicrons get delivered to the liver. So what happens in the liver? So in the liver takes these chylomicrons, these, fairly big triglyceride-rich particles, and it repackages them into something called very low density lipoproteins. So you could see I made them about the same color, but this very low density lipoprotein is actually smaller because the repackaging removed quite a bit of triglycerides and brought in cholesterol esters. So these very low density lipoproteins, or VLDL, are now much more rich in cholesterol than the parent particle, which was the chylomicron, right? Now, VLDL are also the particles that are ApoB containing particles. So for each one a VLDL particle, there's exactly one ApoB lipoprotein on top of it. So this is now one-to-one relationship. And so these very low density lipoprotein particles are then sent by the liver into the circulation. And so what happens when they're sent by the liver into the circulation? Well, there is a lot of them, right? And so there is various enzymatic reactions that start to unload the triglycerides out of these particles and instead bring in cholesterol esters. And so the particles shrink. And when they shrink, they become what very commonly is measured in the bloodstream. They become low density lipoproteins, or LDL, right? And so these little red spheres here are my cholesterol marbles for LDL cholesterol. Now, why is that important? Because patients very often may say, is LDL cholesterol really important? Now, let's talk about it for a minute. LDL cholesterol has been studied extensively in a lot of research studies. Primary prevention, secondary prevention, various types of patient populations. And typically I tell my patients about 40, 30, 20, 10 rule, right? So first of all, LDL cholesterol is very important. It's not the only important part of the lipidome. And it is really important for us to understand all the lipidome connections, but LDL cholesterol is very important. And the 40, 30, 20, 10 rule is an easy way for you to understand why it is important. Because we know, for example, from multiple studies that for each 39 milligrams per deciliter drop in LDL cholesterol, now those were studies across various patient groups, we have a reduction in cardiovascular mortality of about 22%. So I rounded up my 39 milligrams to 40 and rounded down my 22% to 20. That's 40-20. And we also have a 10% reduction in all-cause mortality. Now, this is really important because we are talking about the type of cholesterol or lipoprotein, which is LDL, that most commonly is associated with cardiovascular events. But you could see from these studies that a link was actually made with a reduction in all-cause mortality. And all-cause mortality means reduction from death from any cause. But what is 30? In those very same studies, when you look at them across the board, whether it was primary prevention, meaning preventing the first cardiovascular event in patients who have risk factors, but technically haven't had any cardiovascular events, or secondary prevention patients who have had cardiovascular events already, we have determined from looking at those studies that LDL cholesterol reduction accounts for a 30% relative risk reduction across all of these studies. And that's actually our 30 in 40, 30, 20, 10. Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. So what does it actually mean? It means that if we line up all the patients that were participating in these studies and we compare a group of patients that were treated with medications or interventions to reduce LDL cholesterol and a group of patients who were just given a placebo and their cholesterol levels were not reduced with medications, the difference between those patients in terms of cardiovascular events was 30%, and that's a relative difference. So, for example, we could say that, let's say that in a group of patients who were not treated, let's say we took 100 patients and we determined at the end of our trial that in that group of 100 patients who were not treated with LDL lowering intervention, 10 patients had some sort of a cardiovascular event, right? So you could say, well, this is an event rate of 10%, right? So event rate of 10% is something nothing to sneeze at. It's not particularly high. It's not particularly low. It really depends on what disease you're studying. But let's say there was another group of patients in this very same trial, also 100 people. They were very similar in terms of their characteristics to the group that didn't receive any cholesterol lowering medication. And that actually was our intervention group. And that intervention group had received LDL lowering treatment. And as a result, they have reduced their event rate by 30%. So what that means that instead of 10% event rate, the reduction by a third places them somewhere around 7%. So it's not that they didn't have any events, they just had fewer of them, right? And so this is one of those situations where a relative risk is a very big number, right? It's 30%, but the absolute risk reduction is actually much smaller than that. It's 3% because our group that didn't receive treatment was a 10% event group and a group that received the medication was 7%. So the difference between these is absolute percentage points is 3%. But the relative difference, of course, is 30%. So you could see that there are sometimes, when we talk about relative risk reduction, it tends to make the numbers very large, but the absolute risk reduction may actually is significantly smaller. And the reason why we care is that because absolute risk reduction reduction could be translated into something called number needed to treat. And we will talk about number needed to treat in our subsequent shows. But for now, what I want you to remember is that LDL cholesterol is very important because this 40-30-20-10 rule does apply. But the reason why LDL cholesterol is important in addition to it is that the degree of LDL cholesterol reduction, which is what was studied in a lot of trials, as well as a degree of ApoB reduction, and we'll talk about the differences between the two, has been related to the severity of risk. So for patients who are higher on their vascular risk assessment, there is greater impact from LDL reduction than for patients who perhaps don't have such a high risk level, right? And that sort of makes sense that you will get a greater impact with an intervention, even though that intervention is only 30% relative risk reduction for patients who are sicker or are higher on the scale of vascular risk. Now, is LDL the best marker? Even though it was evaluated in multiple trials and especially statin trials, we have learned over time that we kind of need to take all of the components of the lipidome. So we need to look at the very low density, intermediate density, and cholesterol remnants lipoproteins. We need to look at LDL lipoproteins. We also need to look at other lipoproteins, such as, for example, Lp(a) or small dense LDL, right? So they are very impactful, and together they constitute what's called non-HDL cholesterol, right? Because HDL is in its own category. And when we take all the ApoB containing particles, whether they're chylomicrons that, typically don't get measured well because they kind of, get delivered to tissues and scooped up by the livers. But in terms of our predictive power to understand how our lipidome is actually defining our vascular risk, we know that non-HDL cholesterol is a better predictor of vascular risk than LDL cholesterol. Why? Well, it's obvious because it includes other components that aren't LDL, like all the precursor intermediate forms produced by the liver, as well as a specific derivatives of LDL cholesterol that merit their own discussion. And one of those derivatives is actually small dense LDL. And you could see I made them into these black spheres here, right? So the parent is LDL, and then you have small dense LDL. Why do we care? Because there are actually very significant differences between the LDL cholesterol and small dense LDL cholesterol. Small dense LDL cholesterol is a product or product downstream of the LDL cholesterol. But unlike the parent LDL, small dense LDL cholesterol hangs out in the circulation much longer. So liver scoops up LDL cholesterol, right? There are receptors on the liver that actually take LDL cholesterol back, and cholesterol gets recycled. But if it doesn't get scooped up well enough, it actually, in certain individuals, depending on other metabolic influences, for example, insulin resistance or a lot of free fatty acids, which potentially could happen in some people with ketogenic diet, these individuals then start to convert their LDL cholesterol into small dense LDL. And the problem with small dense LDL is that, here it is, my small little black sphere, sort of like, the most atherogenic particle has yellow for lipids and, black just to let you know that it's probably not the best one to have because it could be quite damaging to the coronaries, right? So here what we've got is a particle that tends to stick around. Now it sticks around in the circulation for a long time, 72, 74 hours. That's almost 3 days. And so when I was at a conference, one of the professionals in attendance said, which of the lipid profile markers makes you most concerned? And, there were various sorts of answers. Some people said ApoB, which is reasonable. Some people said lipoprotein (a), which is also reasonable. But majority of individuals with cardiovascular disease do not have elevations in lipoprotein (a), even though it's been discussed quite a bit. Majority of people have normal lipoprotein (a). And if you look across the board at the genetic factors factors, about 96% of genetic evaluation for elevated lipoprotein discloses no variants. But under the conditions of insulin resistance or excess free fatty acids, and they're actually related to each other, people may start to make a lot of small dense LDL cholesterol. And this small dense LDL cholesterol, these particularly colorful marbles are actually independent risk factors for cardiovascular events, and not just any cardiovascular events, but also related to ischemic strokes and peripheral arterial disease, as well as cardiac mortality. And this actually happens independently of LDL levels. The studies that were done have shown that even in a situation where LDL cholesterol is optimized, the presence of small dense LDL certainly increases person's vascular risk and mortality risk. And this is really important to understand. Now that you understand how these things in the lipidome, how these marbles will connect to each other, you certainly will understand a little bit better why non-HDL cholesterol or ApoB are better predictors of events than LDL, because LDL sort of just speaks for itself. But non-HDL cholesterol includes both LDL, it includes lipoprotein(a), small dense LDL cholesterol, and even these forms that typically are produced in the liver from our chylomicron-derived triglycerides, our VLDLs, and all sorts of remnants, right? So, and typically for these particles, the VLDL, IDL, LDL, small dense LDL, these are all ApoB 100 containing particles. So very often, when patients tell me, well, LDL cholesterol may not be important, it's all about ApoB, that is not really true, because LDL cholesterol is an ApoB containing particle, and it's actually one of the main groups of ApoB particles, right? When we look across all ApoB particles, we are likely to find that LDL ApoB particles are most numerous, but that's not always the case in everyone. And certainly we want to pay attention to VLDL, to IDL, to so-called, remnant lipoprotein particles, as we call them, or small dense LDL. So it's not really true or too simplistic with regard to evaluating someone's lipidome to say that LDL is not important, but ApoB is, or ApoB is not important, but LDL is. There is a relationship, as I had shown you, there is a relationship between other ApoB containing particles that goes beyond LDL. But the interesting part about LDL, and why we talk about LDL, is more than just the fact that it gives us small dense LDL cholesterol that is really very dangerous for the vascular lining and has significant clinical outcome associations with vascular events, that I already mentioned. But we also know that it is LDL cholesterol being small enough, which is the main component found in atherosclerotic plaques, right? So LDL cholesterol gets incorporated into atherosclerotic plaques. It becomes part of a cell called foam cell, which is a derivative of one of the immune system cells called a macrophage. And it goes to the area of injury in the blood vessels, and it attempts to repair that area. And to repair that area, it needs, building blocks for repair. And of course, that's LDL cholesterol. So being small enough, LDL cholesterol could actually be incorporated into the foam cells and becomes a component of atherosclerotic plaques. And so this is why a lot of cardiology trials have focused on LDL cholesterol, even though we know that from more contemporary data that non-HDL cholesterol and ApoB appear to have greater levels of predictive power. And when we use, for example, all the ApoB containing particles in conjunction with triglycerides, we're actually able to discern so-called atherogenic lipid phenotype, or ALP. And at the Holistic Heart Centers, we routinely do it for all of our patients because we're trying to characterize their lipidome and understand where are the levers that we can push with regard to medications, with regard to supplements, with regard to lifestyle, that will actually shift their cholesterol balance in their favor, right? It is not, a rule sort of like the same thing for everyone. There are a lot of nuances, and, a lot of it has to do with a person's baseline level of risk. Are we dealing with a situation where vascular risk is high? Or are we dealing with a situation where vascular risk is low? Is it an individual who is younger or older? Are there any specific illnesses or conditions that may require us to be either more stringent or less stringent, and so on? Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. So then let's, continue to play our marbles game here. And we're going to take, look at these beautiful sort of like spring pastel, summer pastel colored spheres. And so what are they? They are HDL cholesterol, of course. Now, HDL cholesterol is also, the particles of HDL cholesterol are attached to, apolipoproteins. It is not an ApoB. It's something called ApoA1. But you could see conveniently for me, these marbles came in different colors, even though they're the same size. And I think it's a good thing that it came in different colors, because it was actually, we know that there isn't one-to-one relationship between HDL particle and the number of ApoA1 on it, right? There is actually quite significant divergence. And as a result, we don't have that nice one-to-one relationship that we have with ApoB containing particles, right? So ApoA1 could be different, and we may have low HDL number, may have high HDL number with regard to the concentration. We may have variable ApoA1, and there are various ratios that allow us to perhaps understand the nuances of cardiovascular risk when we look, for example, at ApoA1 to ApoB ratio and so on. But what is the role of HDL? So remember how I said it is the LDL cholesterol, of course, small dense LDL cholesterol, that go into the circulation, put itself into the areas where atherosclerosis is ongoing, where there's areas of injury and where there's, plaque repair and so on and so forth. And the HDL cholesterol, though, is what scoops up cholesterol from those areas where plaques are forming and brings it back to the liver for recycling. And so we call this reverse cholesterol transport. And reverse cholesterol transport could be defective in a person. Sometimes we see people who have high HDL levels, right? And they sort of get this false sense of security, and they say, well, my HDL level is really high, so I don't really care if my LDL level is elevated because I'm protected with this high HDL. But what we learned from the literature and for some of the trials that are ongoing is that high HDLs may not necessarily be fully functional with regard to the role that they're supposed to play, which is a reverse cholesterol transport. So how do we know? What do we know about it? Well, first of all, and when we play cholesterol marbles again, with a focus on specifically on the particles, we'll talk about it more in depth. But there are specific subunits of HDL cholesterol particle that are more beneficial than others. And so we know we could characterize this in a more advanced laboratory testing. We can also take a look at the genetic profiles that individuals have and really reconstruct the genetic predispositions of the lipid pathways, metabolic pathways, because we know that there are a series of reactions that take us from these, very low density lipoproteins that are getting released into the circulation by the liver, into the LDL cholesterol formation, into the small dense LDL cholesterol formation, and of course, how HDL affects it by scooping things up and bringing things back up to the liver. So this has been a fairly simplistic game of cholesterol marbles. Hopefully, this is something that you will find useful, because you will understand that this is an opportunity for us to kind of connect all the different pieces of the lipidome together, right? So next time when you come into your doctor's office and you sort of discuss the good and the bad cholesterol, you should probably recognize from my presentation that these very simplistic definitions are actually not useful, because what we need to discuss is how your lipidome specifically either increases your vascular risk or decreases your vascular risks, and what are the pathways inside that we can influence through diet, exercise, supplements, medications that will shift that risk in your favor, right? Sort of like de-risk your lipidome profile, right? Your cholesterol balance. So remember how I said at the beginning, I asked you a question, what is known to be in common between ancient Egyptian mummies and modern humans? And so the answer actually is atherosclerosis or heart disease. There was a very neat study that was done using a whole body CT, where investigators in 2013, they have actually put the mummies from Egypt and a couple of other places in the world, they put them through the CT scan. And so CT scan is a X-ray type of an examination. We certainly use CT scan in contemporary cardiology, both for coronary artery calcium score assessment and something called CT angiography, which is a related but a different procedure. But when they studied these ancient humans, they just did, whole body CT without any contrast. Obviously, have no circulation. They're basically been mummified and, for thousands of years. So what they did find is that about 37% of those ancient humans actually had evidence of coronary artery calcifications. And so we are used to thinking of heart disease as a modern phenomenon, right? Typically in cardiology, one of the most impactful studies to give us an understanding what are the risk factors, what shapes heart disease, a Framingham Heart Study started in the 1950s. And we kind of thought that perhaps heart disease is a condition of a modern human, but we could figure out from scanning these more ancient humans that heart disease was actually also present 4,000 years ago. So it's quite ubiquitous. And if you've been listening to me for a while, you know that I always tell you that heart disease, cardiovascular disease, the process of atherosclerosis is the fundamental process of aging. So when we, for example, look at longevity, or when we take measures with an eye toward wellness, prevention, optimization, longevity, we have to make sure that the number one area we maximize is our vascular health, because the vascular health is related not only to heart health, but to kidney health, to brain health. And the factors that impact longevity are similarly very similar among different areas. If you're concerned about brain health or cancer prevention, or heart attack prevention, or kidney health, you would probably by now already know that the root causes of these, inflammation, immune system activation, oxidative stress, metabolic inflexibility, right? Insulin resistance, and how these interact with our internal and external environment. These root causes are quite similar. They overlap. right? So an individual who is metabolically unhealthy is likely to, unfortunately, be at risk of a lot of chronic diseases. And as always, vascular disease, cardiovascular disease tops the risk. So in our subsequent shows, we will play with cholesterol marbles again. We will play with cholesterol marbles to understand the role of ApoB, to understand the role of LDL particles and different LDL sizes, to understand the role of HDL and even remnant lipoproteins, right? So we sort of will go through all the major stops that, cholesterol balance usually go through and kind of dive deeper into what actually makes up the lipidome and, where you can influence it using diet, exercise, supplements, or medications, and actually where medications work and how they work and why we see side effects with certain medications of a specific type versus the others, and where and what you can and cannot do with supplementation. And this is very important. And let me also kind of give you some context here. So the guidelines for the lipid management are typically authored by professional organizations, and I'm a member of 3 such organizations: American College of Cardiology, European Society of Cardiology, and National Lipid Association. And so National Lipid Association and American College of Cardiology are the organizational bodies that are in the United States, and the European Society of Cardiology is positioned to address the countries of the European Union or countries in Europe. And the guidelines are not necessarily overlapping, although there's a lot of similarity in these guidelines. And the guidelines with regard to how we think or approach lipid management get updated. So American guidelines actually have been updated in 2018. So they have not been updated for the past 7 years or so. The European Society of Cardiology actually will be releasing an updated set of guidelines this year. And so hopefully we will be able to learn more to get additional information about these emerging concepts in lipid management, including non-HDL cholesterol role, ApoB, lipoprotein little a, small dense LDL, and really enhance our ability in trying to figure out how we plug in all these pieces of lipidome together so that you can actually get yourself in a better place with an eye toward lowering your cardiovascular risk and improving your heart health. Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Card Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Card Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticcardcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.